So after you get your implants out, what can you do to make them look as best as possible with all that extra space from what the implant has been?
Right. So when we talk about implant removal, I say you can take them out. You can take them out and do a lift. You can take them out and do a fat transfer, or you can take them out, do a lift and a fat transfer. Now, some surgeons don't like doing fat transfer at the time of implant removal. I don't mind doing it. It depends. Everything always depends, right? It depends on I think the most important thing is what's your implant to breast tissue ratio? Are you all implant and no breast tissue? Are you 50-50? Are you the awesome patient that has 200 cc implants in and D breasts, so you have you're not even going to miss them? Like I see less and less of those patients. Sometimes those are patients in their 60s. They've gained, 50 pounds over the last 20 years. And so they're not going to miss their implants at all. Those are very rare. Again, Southern California is full of teeny tiny people. So my 60-year-old patients, I think, and older are like skin over implant. Like they're just so tiny, right?
And some of them are so incredibly hard. They're they're like little dinosaur eggs. I don't know how else to
Yeah, the
explain it.
ruptured,
Yes, and they're
encapsulated implant.
so yeah, some of them you take out and it's like calcified.
Right. So those are the most challenging, I think. And those patients actually I've started to stage. And I just had someone recently where I was like, I have to take them out and then let your tissues recover because you're literally skin over this hard ruptured implant. And then we can figure out what's the next best step. So, okay, so the most challenging are the dinosaur eggs, the ruptured implants that have been sitting there for 20 years, and the ladies who have, super large implants and started with type A breasts and they have size A breasts and they still have size A breasts stretched out over that implant. So those are the most challenging. I tell patients that, when you take the implants out, shockingly, your nipples don't fall to the ground. Like people are super worried about that. So if your nipples are, staring at the wall or the mirror, they're not going to fall when we take them out. So the reason to do a mastopexy are either to raise the nipple areolar complex or to reshape the breast. So for some patients, if their nipple is in a good position, then we're just doing it to reshape the breast tissue that's been stretched out. For patients whose nipples are falling off their implants, that so-called waterfall deformity, where the implants are staying high, but the breast tissue has aged and fallen off the breast, then I strongly recommend doing a lift when you take them out because they're also not magically going to come up. The nipple's going to sort of fall backwards. So wherever it is, it is. And then fat transfer is usually an effort to restore volume. So we can put fat in to restore volume. Again, if you have a 200 cc implant, it's a little easier to put 200 cc's of fat in than 800 cc's. And then it also depends on the patient. If you have no fat, kind of hard to scrounge. I can usually scrounge around, but every once in a while someone challenges me on that. I think the lady we saw had a BMI of 16.
So tiny.
Literally that's when you're like, I need someone to donate fat for this because there's no way.
That's when you have to look into purchasing the fat.
That's right. Fat in a syringe.
Exactly. But we still found some.
Yeah, we have done
Done patients where we've definitely put in some work.
Yeah, to get the fat for sure.
Yeah.
So
yeah. And by work, it's her lipoing. I'm just
Cheering
there
me
for
on.
moral support. Yeah. Faster, you can do it.
You're doing a good job. So I think it's important to know these are all the options. And so that for that reason, our consults for these procedures are generally a little bit lengthy. And for people who are like open books and have no idea what they want to do, or even aren't sure if they want to replace the implants, I usually do a two-time consult. So we talk about all the options. And then when you start to think about it, narrow it down. Okay, I think I'm going to do this in a lift, or I think I'm going to exchange it, or I think I'm going to do, then we can have a more refined conversation about what that surgical plan is. So it is a lot to take on. And I think, and most patients have a lot of questions truly related to what's it going to look like when I remove these. So I think it's important that they have a good sense of why they're doing it and what it's going to look like afterwards and kind of what the long-term effects are.
Right. Because everyone's different. So.
Yep. We're all snowflakes or thumbprints or whatever. I don't know.